So we will get started. It's just going to start recording now. So welcome everybody. My name is Amy. I use she, her pronouns. I am currently acting coordinator of the Population Health and Community Development team at WAAC. And Gary, would you like to introduce yourself?
Yeah, hi. So, so I'm Gary. I'm one of the nurses with the M Clinic. I've been with the M Clinic since its inception, which is coming up 16 years. And I'm a he, him, and also fabulously very good compliment to be also delegated the nurse educator for WAAC. So enjoy the education component of what we're going to be doing today.
Alrighty, so before we get into the session today, we would like to acknowledge that we are meeting on, well, for ourselves, we're calling in from the lands of the Whadjuk people of the Noongar Nation. I'd like to pay our respects to elders past and present and extend those respects to the true custodians of the lands from which everyone is calling in from today, recognising that we do have people joining us online and maybe watching this back from right across Western Australia. So we recognise there always was and always will be Aboriginal land. So a little bit of housekeeping before we get into the session. There'll be very little bit of admin from me from the beginning, and then we'll get into the content. So the session today is being recorded. So we have started recording from now. So we do ask of you, I would keep your microphones off throughout the session today. If you do have any questions, please pop them in the chat. We will try and get to them while we can through the session. Otherwise, we will have time at the end that we can answer them for you. If you have a pressing question that you want to pop it in the chat so you don't forget it, please do so. We can get around to it when we have a moment. So as I said as well, please keep the microphones off. And if you do have any questions, recognise that everybody's coming with different understandings and different levels of experience with PrEP. So this is an open learning space. So we encourage any questions. If you have a question, guaranteed other people are probably thinking of it. So please ask. There's no such thing as a silly question. And we again understand that everybody is maybe your first time hearing about PrEP as well. So recognising the different experiences there and levels of understanding. Last bit as well, and I will be bugging everyone online afterwards. So please complete the online evaluation. There will be a QR code at the end of the session, and I'll also put a link in the chat. So I'll ask you to fill out that evaluation form. And if you're watching this recording back, where you got the recording link, there'll also be a link to an evaluation. So you're not exempt from this too. This will help us inform future sessions that we do, any feedback you have, so that we can continue delivering this education to healthcare workers right across WA. So very brief session overview. So we'll do a bit of a deep dive into what PrEP actually is, how it works in the body, what it looks like. So who can take PrEP? So the different kind of PrEP options that are available, and the suitability and kind of behavioural kind of risks and criteria and everything when it comes to prescribing PrEP. So how to actually go about prescribing PrEP, what that looks like and the follow-ups involved in that. And then on the other side of it, when accessing PrEP for your clients, how different ways that people can access PrEP. So the costs and the different programs involved in that. We'll then do a little bit of a look at the future of PrEP. So we know that there's lots of different medical innovation that is constantly evolving and changing in this space. So looking at what is kind of on the horizon for PrEP options and some really exciting things, hopefully in the pipeline. And then there'll be some referrals and supports that we both listed at the end of the presentation today, and also sent out in the follow-up email with the recording in the next week. Ready to get into it?
Absolutely, let's go.
Awesome. Alrighty, so what are we actually talking about today? So we're talking about PrEP. PrEP stands for pre-exposure prophylaxis, and this is a pre-exposure prophylaxis for HIV. What it is a co-formulated two medications in the one tablet, so tenofovir and emtricitabine, and it is a medication that's taken prior to any type of risk event. So, for example, prior to sex, and it's up to 99% effective at preventing HIV transmission. For example, there, so with the 99% is through sexual contact. So this is the pill that is taken, and there's different ways which we'll go through in a moment, the way that it is taken, but it's prior to a possible risk event. So PrEP in Australia, so I'll go through a little bit of a timeline in a moment for how PrEP was introduced in Australia and the current landscape of PrEP. In Australia, PrEP has been one of the really effective tools and really has had a really positive impact in driving down the number of new HIV notifications every year. So PrEP was introduced, you can see here, when the trials began, so around 2016, and to when it was introduced on the PBS, so going through to 2018, 2019 there, we start to see that decrease there with the introduction of PrEP. Of new notifications. So it's predicted that PrEP has reduced the incidence of new HIV notifications by 92% over 3 years versus what the kind of historical expected incidence was to be. So we're at much lower incidence kind of rate than we would have expected to have been if PrEP wasn't introduced within Australia. So a little bit of timeline about, so PrEP has been around in Australia for quite a while. So the trials first began in 2014, so the different clinical trials, and those concluded in May of in 2016, where then Truvada as PrEP was approved by the TGA. So these are state-led trials. These were amongst men who sex with men. These are the initial trials with the introduction of this particular combination of PrEP that is now on the PBS and used quite regularly, extensively across our communities. So it was listed on the PBS in April of 2018, and then going further on from there, so that's talking about PrEP in tablet form. In August of 2022, cabotegravir, which is a long-acting injectable form of PrEP, was approved by the TGA. This still currently is not yet PBS approved, but we'll talk about a little bit more in a moment. At the end of last year, a new novel drug and also a long-acting injectable form of PrEP was also approved by the TGA. So this is called lenacapavir. And so this is, again, not yet PBS approved or not yet listed on the PBS, but we'll be looking to go into that next phase of those kind of negotiations and discussions between the pharmaceutical company and the PBS. So as of end of last year, so as of December 2025, in Australia, over 97,000 people had ever received PBS subsidised PrEP. So that is not including those who are accessing PrEP off of the PBS, just those who are Medicare eligible and able to access the PBS. So as you can see, it has had quite a great reach across Australia.
No, thank you. Fabulously well. Almost don't need me.
No, we do. The next section we do. So over to Gary now about how PrEP actually works in the body.
Okay, so HIV, it actually there's receptors on the outside of your CD4 cell, so it enters in, and then what happens is that there's an enzyme in the white blood cell called reverse transcriptase. So HIV is an RNA virus, and then the reverse transcriptase enzyme actually then means that the HIV virus can integrate into the DNA of the cell, which is then converted to DNA, and then it's reconverted. So basically what it's doing is saying to the proteins in the DNA, make more of me. So it's just a mechanical process. And then once it leaves the nucleus of the cell, it reverts back to an RNA virus, and then anywhere up to 1 million or so copies can be produced by one cell. So then when we look at that's okay. So when we look at how PrEP works, the medications actually block the reverse transcriptase enzyme. So it means that the virus, the RNA virus, is not able to integrate into the DNA, and therefore the process of creating more virus is blocked. So basically the way I look at it, when I'm talking to clients that go, how does it work? It's like, well, HIV gets into your body, but the presence of these drugs actually then just basically blocks it and says, no, I'm not going to let you, transform into DNA, and therefore you're not going to make any more copies. And it's incredibly highly effective, as Amy said, up to 99%. So then the virus can't replicate, can't escape, and then infect more cells. So it's fairly simple, but I think that's, I don't think we need to go into the deep science of it. Okay, so as far as who can take PrEP, initially it was men who have sex with men. Historically, the highest risk group for contracting HIV. So what is important is that I think there's still a bit of thinking among certain, doctors or clinicians that, oh, really, it's only gay men or other men who have sex with men that are at risk. Anybody who's having sex with multiple partners and not using condoms is at risk for sexual transmission for HIV. So anybody, so what we need to do is not go, oh, you're gay, therefore you're at risk, or you're this and you're not at risk. It's we look at what is the actual behaviour. So if you have a heterosexual female who says, oh yes, I have receptive anal sex or vaginal sex with multiple different partners, they're at risk for HIV. So it's asking about behaviours. Don't say, oh, you're gay or you're this or you're that. Then it's just let's look at the behaviour. Who do you have sex with? What kind of sex do you have? And it's really important to completely, I know it's easy for us because we specialise sexual health, but it's really important to normalise the conversation and go, oh, actually, while you're here today, one thing that's really what we like to do and try and normalise it is we talk about sexual behaviour. And we want to talk about, if you're having sex with multiple partners, and I always say, I really care, but I don't care. Have sex with whoever you like. It's really about what can we do to protect you. So, as I said, there's still this thinking that it's mainly, gay or bisexual men that are having sex with other men. So we need to sort of break that mold. And when I'm talking to heterosexual men, for example, they're like, oh, I didn't know that was available. So it's something that's really good to just get rid of those sort of stereotypical thinking. Look at, and if you need to know, to say, how do you identify? But we can talk about, people that are heterosexual identifying, but do have sex with the same sex. So that doesn't matter. Let's look at the behaviour.
Absolutely. And we have there as well, anyone who asks for PrEP should be considered. So if somebody is aware of PrEP and is asking for it, whether or not they may actually be disclosing, they may not be disclosing all the kind of behaviours, but if they have an interest in it, should be kind of considered that conversation. But then also looking at other considerations as well for when to bring up PrEP as well. We'll go through these in a moment, but looking at some patients may actually not be even aware of PrEP. So like Gary was saying as well, talking to people who may not be aware of PrEP, and particularly so if people haven't received, PrEP messaging, or amongst we know, gay, bisexual men, the community and gay communities have really kind of good the social connections and real kind of good kind of community understanding around PrEP. And there's been a lot of onus that's been put on gay communities. But when it comes to in terms of messaging, so messaging for PrEP as well, outside of that, often may be quite limited, or people may not be aware of it. Sexual partners may not bring it up. So it's being the ones to instigate the conversations around PrEP, because people may have no idea. If they have no idea about it, that they can't make an informed decision on the best ways to take care of their health. So they may not even be aware of what their risk is for HIV as well. They may have other kind of misconceptions or outdated understandings of how HIV works as well. So bringing up whether someone else has initiated the conversation or not. Just adding that bit in before we got onto this.
Yeah, no, this is good, because the notes are to the side, and I sometimes go on a roll and I forget to check the notes.
No, that's all good, all good. So I guess other considerations for raising PrEP in a consultation, and so Gary spoke to this before as well, if you are kind of talking about sexual behaviour, kind of sexual health or sexual history taking as well as a part of regular health checks. First of all, framing that within the broader context of health. And that may also help, if you're doing like STI consultations, contraceptive consultations, or conversations around that, family planning, those kind of discussions. Young people as well that might be becoming sexually active, where we might be having those other conversations around their health and wellbeing, including the conversations around PrEP and looking at those kind of risk assessments there as well with young people too. again, if people have new or multiple partners, people traveling overseas. So we know that there are areas around the world that do have, and countries that do have a higher prevalence of HIV. And we know that overseas travel, international travel, does increase the risk of acquiring HIV and other STIs as well. You know, because of different behaviours and risk-taking behaviours people engage in when in different environments to their everyday environment, or their risk perceptions may be different and change as well. So maybe they're not aware of the risk as well. So initiating it within, always encourage, if you are doing a travel health consultation, we talk to travel health doctors as well about this, quite a bit about including this as when you do all your other checks of vaccinations and other kinds of preventative measures that you would take for somebody's health travelling overseas. If someone's indicated that they've used PrEP, so post-exposure prophylaxis for HIV in the past, that could be a good indicator. There could be an indication there that PrEP could be suitable, or even generally expressed anxiety about HIV or other STIs as well. If it's impacting somebody's quality of life, impacting their if their anxiety around engaging in sex and relationships as well, and maybe preventing them because of these anxieties around HIV and other STIs. Having those conversations about what the options are as prevention, and for that peace of mind as well. And again, being able to make those informed choices for themselves.
I would also say, many of you might be aware of this, but when I've spoken to people about PrEP, and they go, oh, well, I've had PrEP before, and they think, oh, is this a different medication? It's exactly the same medication. One is used for prevention and one is post-exposure. So it's exactly the same medication. So, yeah. Okay, so one of the contraindications, then, we'll get to your question, Steph. Let's hold that thought. So contraindications, if people are HIV positive, well, so then it could be exactly the wrong drug for them. And there are far better drugs these days for HIV treatment anyway. Also, there is a potential for the PrEP medication to impact kidney function. In otherwise well, healthy people, it's unlikely to cause significant issue, but if they have a pre-existing renal disease, then it is definitely contraindicated. There is a more kidney-friendly version of PrEP, which we may mention a little bit later, but currently just talking about what I call normal PrEP. The other contraindication is where people have chronic hepatitis B. So there has been a little bit of a change in the clinical thinking about this, but generally, so the tenofovir part of the medication can be used, and if people are actively replicating hepatitis B, it can be used for long-term management to suppress the virus. So for a long time, it's been if people actually do have chronic hepatitis B, once they start taking PrEP, they should never come off it because of the risk that the virus you'll have a viral flare. So it's generally recommended. As I said, there has been some change in thinking whether or not it's possible that people could go for on demand, which we'll explain that in a bit. Generally, chronic hepatitis B currently would say contraindicated for intermittent use. It would have to be daily and ongoing.
So that's a great segue onto the different types of PrEP, or different ways, not necessarily the types of PrEP, but maybe also the ways that PrEP can be taken. So there's two main ways that the PrEP pills, so that co-formulated medication can be taken. So one of the most common ways, or the most common way, is taking it as daily PrEP. So this is a pill once a day, one pill once a day, and this is one of the most widely, I guess, available forms of PrEP, or ways to take PrEP for most people. So, which makes sense when I explain on-demand PrEP. For many people, so apart from cis men, requires a 7-day lead-in of medication to ensure adequate, or to reach adequate protection. So you'll see in a moment as well when we talk about on-demand PrEP in terms of where the recommendations are of who can take the different types of PrEP schedules. The reason for this is because it does, there's been studies to demonstrate how the found that PrEP can take a bit longer to uptake in particular to reach kind of a protective level in particular tissues such as vaginal tissue compared to penile tissues, and also interactions with different hormones as well, and hormonal medications too can have implications for the lead-in time and how long PrEP takes to be effective, and also how long someone needs to be on it after exposure as well, which we'll go through towards the end. So PrEP, that's a 1 pill once a day and can be ongoing and as somebody requires. So on demand is another way that PrEP can be taken. So this is only suitable for people assigned male at birth with risk of HIV from sexual exposure. So this is the wording from the ASHM guidelines. The idea for on-demand PrEP is that it can be used for a short period of time or around single events of HIV exposure. So you can see here on the calendar here, so requires taking a dose of 2 pills anywhere between 2 to 24 hours before, for example, before engaging in sex. And then taking another pill 24 hours after the event, and then another pill 48 hours after the event. So it has those kind of 2-day lead-in. So it's sometimes referred to as 2-1-1 scheduling. So on-demand PrEP, event-based PrEP, there's different terms people might use for it. So the only times where it isn't suitable, so it's only suitable for people assigned male at birth. And this is not using estradiol-based hormones or exogenous estradiol-based hormones. Does not have chronic hepatitis B with liver cirrhosis, as we were speaking about before, because it is that kind of that kind of sporadic kind of stopping and starting of PrEP, and doesn't have a significant again talking about significant renal impairment as well, which is again a contraindication for PrEP in general. So this is a different kind of scheduling here. It can be taken, so say if somebody was, say they were going away, or if somebody, so a cis man was starting PrEP, that they would be able to take the 2 pills either 2 to 24 hours before a possible exposure, and then continue taking on daily PrEP onwards from there as well. So this also could be a way that it can be started too. So it needs that shorter lead-in time with those 2 pills to be effective, again, only for cis men.
No.
Is there a more common one that you see in practice that people, is there where people's preferences might be, or where it might change?
Yeah, it's highly variable. I think like most of our clients are very well informed, and a lot of them will take it daily, and then they think, oh, okay, I'm not actually having sex that often, so they'll change to on demand, and then they might go on a holiday and go, okay, I'm going to take it daily while I'm away. And we just emphasise, if you've taken it daily for, let's say, a month or so, that they must remember to take those two more days after the last occasion of sex without a condom. So we've got quite a mix, but I must say the on-demand is still not available. Still not as oh God, what's the word? People aren't as aware of it.
Yeah.
And so they're going, oh, I didn't know that I could take it, because back in the the early days of PrEP, it was always take it daily. And then sometimes like, oh, I didn't know I could take it on demand, because people don't want to take a tablet every day if they don't necessarily need it. Mm-hmm. So the question that just popped up, is it as effective? So if you look at the overall research, as long as people take it as prescribed and they're not missing doses, then you've got perhaps a slight variation between the effectiveness, but essentially we're saying it's up to 99% protective for both forms of taking PrEP.
Exactly, like you said, often it's the I guess the kind of user error, I guess, where the margin for error comes in if people are forgetting to take those doses, or so say like, or I guess say something like on demand would require a little bit more preparation and planning as well. So where or taking daily pills might be a bit of an easier reminder for people and things like that.
That's a really good point actually, because when people are taking daily PrEP and they go, oh, I missed a dose there and I missed a dose there. Because of the relatively long half-life, the occasional missed dose is fine. And if you look at the research, it was 4 to 5 tablets a week is adequate. We don't tell people that. We say take it every day to make sure that they don't slip into, oh, I've missed a day or two, I'm not going to worry about it. But if they do say, I've missed a dose, I'm panicking, 1 dose here or there is no big deal. With the on-demand PrEP, as Amy said, it does require emphasising it must be the 2 and 1 and 1. So missing either of those second doses is a problem. So it's and it does often, like, you'll get reports about people that have been on demand PrEP that have acquired HIV, but you need to dig deeper to see, okay, how were you taking it? Some people say, oh, I took it just before sex, I took it just after, or I missed the second dose and I took it the next day. So you've got to really emphasise the adherence and the planning when it's on demand. So they're little pill boxes. They're not just for old people. It's really good for people to go, oh yes, have I had my dose or not?
So the tools are there.
Yeah.
So we spoke a bit before about PrEP, so post-exposure prophylaxis. So this is a way of taking these preventative medications after a potential exposure to prevent HIV transmission or acquiring HIV. So it works the exact same way within the body. The most common way, and most times you will see PrEP being prescribed as the same drug that is used for PrEP as well. So again, that's kind of that co-formulated, that 2-drug regimen, the combination pill, and working the exact same way on the cell as well and preventing that HIV replication. So it's approximately 80% effective at preventing HIV after potential exposure. The effectiveness of it, though, does depend on how soon afterwards it is started. So the sooner it's taken, the more effective it's going to be. It must be started within 72 hours after potential exposure, not longer than that. Again, the effectiveness there drops off. So again, the sooner it's taken, I sometimes compare when looking at PrEP versus PEP. People are quite familiar with the concept of the pill, someone taking that before having sex to prevent pregnancy, and then taking the morning after pill after sex, potentially for potential for pregnancy. And again, needs to be started with that really short time frame. Again, of course, talking about the pill, that's talking about contraception and preventing pregnancy. But here we're talking about HIV, so just again delineating there, but it's a similar kind of premise. Except instead of the 1 pill, PEP is taken as a 28-day course of medication. So about a month worth of medication. So this can be prescribed. So previously, PEP was only available from hospital emergency departments, and also where there was an S100 prescriber as well, because it was only able to be prescribed as HIV treatments are by S100 prescribers. A couple of years ago, there was a change in the guidelines, which now allows for GPs and nurse practitioners to prescribe PrEP for use as PEP. So it can be prescribed as a 28-day course, also 1 course of PrEP, and no repeats of that, and again to be used as PEP. So different ways that this might be used, and speaking to clinicians prescribing these. So in the context of travel, for example, if somebody is traveling overseas, that maybe they don't think that they need to be taking daily PrEP. They maybe don't think that there could be a risk, that there is a risk, but there is a chance there could be. If having a script like this that they can take and fill and can use that if in the instance where there has been a potential risk exposure, that they can start taking the medication as PEP immediately afterwards, because access to PEP in other countries is far more limited. Similarly as well, access to PrEP as well. It is regulated very differently in each country. Not every country has it available as well. So again, people can still go to emergency departments, particularly if it's after hours, or maybe that is the easiest access for them to go to. There is a phone line that they can call. So if someone goes on to Get PEP, or looks up Get PEP WA, there is a WA specific page that has got the different hospitals listed, both regional and metro areas across WA that will stock or do stock PEP. And has also a phone line that is staffed 24/7 that people can call if they have any questions, if they're not sure if they need to take PEP or where to go, or if they're having trouble accessing it, say, for example, from an emergency department as well. But coming back to the reason we're talking about it in the context of PrEP is, one, because it's important people are aware of this and the difference between them, but that also, again, most common way that PEP is prescribed and is taken is the same medication used for PrEP.
And one other thing, like with the approximately 80% effective, this was the medication was started to be used for people who, like healthcare workers that may have had, like I say, a needle stick injury or other penetrating injury from someone known to be HIV positive and not on any treatment, it was shown to be approximately 80% effective. So if we're looking at sexual exposure, it's really difficult to sort of quantify. Well, we're going to have to check anyone who's been potentially exposed actually to somebody with HIV. It's easy to monitor that in a hospital setting or a clinical setting, but you can't monitor it really in a real world situation. So if we take this from a clinical situation where there was potentially active inoculation, then I would assume that it's going to be even more effective if somebody's been exposed through sexual exposure. So, but absolutely emphasise sooner the better, yeah.
I do have a question there about, so who does ED call for advice? So it's usually, so it'd be the encouragement for the on-call immunologist in immunology?
Yeah, okay. So just talking a bit aside about emergency departments, I think you might have a note about this after, but some emergency departments or triage nurses will never have heard of PrEP because, PEP, sorry, and so I think what the info line and what we do, go into an emergency department, tell them this is what it is, this is what I need. And so the triage nurse, whoever, wherever they present, would need to talk to, that's okay, Jess, no problem. But when they do go to an ED, triage nurse they'll be contacting the on-call immunologist to make an assessment, and they're provided with a 7-day pack and then referred back to a sexual health clinic for further follow-up. So we do have an info line that we take here at the M Clinic. So we then we make an assessment and decide, yes, I think you really do need PEP. If we're a little bit unsure, or if it's out of hours, then the PEP line is available. And if somebody's in a real panic, it's after hours, it's like an ED, or you might be lucky enough to find an after hours GP. So this might be mixing this up a little bit, but some GPs will still think, oh, I'm not an S100 prescriber, but you do not need to be an HIV prescriber. S100 prescribers also prescribe for hepatitis B. Any GP, any nurse practitioner can prescribe PrEP. So that really opens up a lot more opportunities for people as well.
Good segue.
Oh, good.
Good wrap up there. So the last step we'll talk about is the long-acting injectable PrEP options. So currently we know now there is now 2 that have been approved by the TGA, but the one that was approved, we have more information on that is being more accessible, is the Apretude, or it's cabotegravir, which is an injection given every 2 months, and it's a long-acting injectable form of PrEP. So it works slightly differently to how the pills work. So the pills we currently have available, so these are integrated strand transfer inhibitors. So simply what they do is they work on a different part of the HIV life cycle, the process for HIV replicating, and prevents that replication into mature HIV particles. So again, it has the same outcome, but just works in the cell in a slightly different way. So it was improved back in 2022, but they are still in negotiations with the PBS in order to be able to get it onto the PBS. So not yet, there's not yet subsidisation for this available. There is a, so through ViiV, which is the pharmaceutical company that has, that provides Apretude, there is a limited access is available through the Compassionate Access Program. So this is something that it's something for somebody who may really require something like this, like long-acting injectable PrEP. So oral PrEP is not suitable, but there is a high risk of acquiring HIV that may be considered for the Compassionate Access Program. So there is, again, limited availability for this, but still recommend for clinicians when they're applying for somebody to access this as well, to still go ahead with it, and that in case there is a bit of a wait list, and then that they can then join onto it if somebody does drop out of the program or no longer needs to access to the program as well.
Yeah, so one of the reasons for this Compassionate Access Program is where people are unable to tolerate daily PrEP. So it means people we know, known to be at high risk of acquiring HIV, and for various reasons, people are unable to take the tablets because of side effects. Some people are in home situations where if their PrEP tablets were found, it could actually be dangerous because that would be outing them as to their sexuality and sexual behaviours. And there are some people that are incredibly chaotic, and taking regular medication is just really not practical. So then these long-acting injectables are going to be an absolute game changer for a lot of those people, as with the long-acting injectables for HIV treatment, which have been around for a while. So yeah.
So it's been a little while, but we're still saying, you know, fingers crossed, and we'll watch and wait to see, hoping to have more, and in the near future having more open access to long-acting injectable PrEP as another option as well. So prescribing PrEP.
Okay, so once the potential risk for acquiring HIV's been identified, then it's a discussion between the clinician and the patient. So what is required is, and this is in an absolute ideal situation, we're not talking about an emergency situation where somebody could have been exposed. So this is where somebody comes, they says, yeah, I'm interested in PrEP, or it's been recommended, and patient says, yeah, I'm interested. So what we need to have is a negative HIV test to begin with. It could be the wrong drug for someone to start taking if they do actually have HIV. And because of the potential impact on kidney function, we need a EGFR. And for those clever people out there, will know that it's estimated glomerular filtration rate. So it's basically a mathematical calculation as to the effectiveness of the filtration rate of waste products through the kidneys. And then we also order a urine protein creatinine ratio. Nobody should have really high amounts of protein in their urine. They're large molecules, and loss of protein can be an indicator of pre-existing kidney dysfunction. So that needs to be checked. Always, probably obvious during an STI screen. And hepatitis B must also be checked. If they're not immune, to get them vaccinated, and also to make sure that they don't have chronic hepatitis B. So it may not be suitable for people who are pregnant. So if you've got somebody who may be pregnant, pregnancy tests must be done first, and vaccinations for people that are not immune to hepatitis B, and also hepatitis A. So with the there's always a review then, which should be done at 1 month to check adherence. Are people coping with the side effects? We always repeat this HIV and syphilis because we have a similar window period up to 6 weeks for HIV and syphilis, and depending on the person's age and general health and whatever, a repeat kidney function can be done, usually just the UEC, which will be the creatinine and EGFR. So yeah, absolutely checking adherence. Some people will say, look, I don't have sex very often, I may not even start taking it. It's always good to do a follow-up window period test if they've had an exposure not too long prior to when they're going to be starting PrEP. And if people are going to be intending to take it on demand, often I think it's a good idea that people take it every day for 1 month, because you will often get gastric upset. It's probably the most common that people will experience. For most people, that will actually settle down. So it'll be a good way for them to check, if they're able to tolerate the medication. Kidney toxicity is quite rare. There's actually a syndrome called Fanconi syndrome, which could put somebody into acute renal failure. It is extremely rare. But if people have other comorbidities such as diabetes or pre-existing renal issues, then that's something that obviously needs to be monitored, and people may not be able to continue on it. So other things that need to be taken into account that can also affect kidney function is the non-steroidal anti-inflammatory drugs. So if people are on high doses of anti-inflammatory drugs such as ibuprofen or naproxen, and also people that have high protein intake. So we have a lot of clients that do a lot of bodybuilding, a lot of gym workout. They're working really heavily, and so basically the metabolites of those medications and the protein has to be filtered through the kidneys. So if you're then adding an extra layer of pressure onto the kidneys with PrEP, we have seen people's kidney function deteriorate over time. And for some people, it's been do you want to continue with your high protein intake and bodybuilding, or take PrEP, because with the current medication we've got available, it's a choice of this or that. So some people have just had to back off on the protein intake so that they can actually continue taking PrEP. So what else do we need to do? So if people are taking PrEP daily, or if they're taking it frequently on demand, so even if it's, might only be a few times a month, then usually it would be recommended to have a checkup every 3 months, always including an HIV test, regardless, even though we know that it's highly effective. We do want to check if ever there's a potential failure, and a full STI screen every 3 months. And the recommendation, unless there's other potential issues, then kidney function should always be checked every 6 months. So if you've got people taking it, occasionally, then some people think, I don't really need to test that often. We'd still recommend 6 monthly is a really good default. Some people go, look, I only have, I might have a few hookups, in a year, and then it can be up to them whether they decide that they want to test, a bit less frequently. But in general, I'd say 6 monthly, and it's particularly because we've got such another wave of syphilis, and we have other things on the side. Monkeypox has had a bit of a rise, so that regular testing is really important.
Cool. So what it looks like on the other side for actually getting PrEP. So PrEP, so in the tablet form, is PBS subsidised. So it's available from most pharmacies. So on the PBS, it's about $25 a month. So as most PBS medications now are available at that cost. With a concession card available for $7.70 a month. It's also available in the Closing the Gap scheme as well. So that could either be a subsidised cost or at a waived cost as well. There a new program, or a new very exciting thing that's come up for in 2026 in WA is that we now have a program for people who are Medicare and eligible to access PrEP for free. Whereas previously has needing to be accessed obviously through. For all of these, you still do require a script from either GP, nurse practitioner from a health clinic, and then accessing it either through the pharmacy at full cost without PBS subsidy, or accessing it through a personal importation scheme, so accessing it from overseas pharmacies. So it's previously the only options available for accessing PrEP if people are Medicare and eligible. Now in WA, we have got a new program, so it's run through the public hospitals in the metro area, but services right across WA. So in order for people to be able to access this, if they are Medicare and eligible, they can visit the PrEP West website, which I have down the bottom there. So that's a website created with WAAC in collaboration with the Department of Health in the creation of this formation of this program. There is an eligibility checker on there. But they also, if people are interested and wanting to know if they can access it, or in terms of criteria without having Medicare who can access this program. What it requires is booking an appointment through Royal Perth Sexual Health Clinic, or through the South Terrace Clinic based in Fremantle Hospital. This can be either in person or telehealth, so this can be done from regional areas as well. So again, it's booking a specific appointment for the Medicare and eligible PrEP. Once somebody's received the prescriptions this way, so this is accessing the prescription through this program, and these appointments are also free of charge as well without Medicare. Then going, so then the prescriptions being dispensed through either Royal Perth Hospital Pharmacy or Fiona Stanley Pharmacy. And again, these can be delivered to regional areas as well, so it doesn't have to be dispensed in person. So again, access right across WA as well, but needs to be accessed through these clinics and also through these pharmacies as well, for them to be able to access free PrEP. Got my words muddled up there as well. Just Director, we do have a question there in terms of going back with the side effects of PrEP. How do many people find that they have to stop PrEP because of the side effects?
Yeah, Jordan, I don't know if I might have partially answered your question already, but overwhelmingly, no, people don't need to stop due to side effects. So we've had some people that have had horrendous nausea, diarrhea, bloating, simply cannot tolerate it. I'd say that's very much in the minority. Very few people that I've come across have had to do that. It's not uncommon for some people to feel some nausea, especially after taking the 2 tablets. You know, they're taking it on demand, so you get a big dose of the drug. So there's no reason why people can't be prescribed something like ondansetron, which is quite a potent anti-nausea drug, and that's relatively common for people to do that. So overall, no, I would say the majority of people, if they do have initial side effects, they'll settle down, and some people say never had a side effect ever. Yeah.
Maybe also while I'll hit the questions here as well, just in case anyone needs to jump offline before we get around to answering at the end. So Steph's question around, can people under 18 take PrEP?
Right. So initially, the trials were only for people 18 and over, but I'm trying to think if we have anybody under 18 that's actually on PrEP. So I don't think we've got anybody here, but if we're doing an STI, we can see anyone aged 14 and up for an STI screen. That then, if they need treatment for, if they need vaccination, treatment for syphilis, treatment for gonorrhea, treatment for chlamydia. Of course, there's always, at that age, we're looking at whether or not they're in any kind of relationship where there's a power imbalance. I would have to double check whether the guidelines stipulate under 18. From a clinical perspective, I would say
they have considerations for it. Yeah. So for considerations of under 18 or for young people, for youth, they actually have a tab as considerations for that as well.
So, I mean, it would be remiss if you know you've got a 15, 16, 17-year-old person that's having regular sex without condoms to say, no, I don't think we should give you PrEP because it's not stipulated. So from what I know about even just talking about assessing a mature minor, it's like, well, you make an assessment, and if this person's at risk, I don't think that's something that I need to talk to our medical director about that, just to absolutely qualify when people are under 18, what the considerations would be. But from my point of view, if they're at risk, prescribe.
I know when it comes to the, as I was looking into this actually the other day, and they, it was around that and something that I know that Fergus said everyone asking in terms of the who can actually access PrEP, and the main consideration, I guess, if somebody is younger as well, or of anybody as well, is around over 35 kilos. So that's where if someone's under 35 kilos, there's different considerations there, but the weight as well. So if somebody is over 35 kilos, under 35 kilos, there may be different considerations for PrEP in terms of suitability, but over 35 kilos, and it doesn't necessarily have to obviously do with age as well, that PrEP will be effective. But obviously there's other considerations as well when working with minors too. But there's actually on the PrEP prescription, the PrEP guidelines, for the ASHM guidelines, which I'll send out in the emails out, or if you want to have a look at them yourselves, there is a section there around prescribing PrEP for minors as well.
I love your question, Stephanie. Thank you for that.
Thank you all for those questions. Last couple of slides here around stopping PrEP.
Okay, all right. So I think probably mentioned this before, whether people so cisgendered men taking or people born male, if they're taking PrEP daily, then it's absolutely vital that they do take the 2 more days worth. So last occasion of sex, okay, that's it. Not going to have sex for a while. Then it's 1 and 1. So they must take those 2 tablets. If so, for cisgendered women or trans men, for example, then the whole issue of starting and stopping PrEP is quite different. So there has to be a 7-day lead-in. And then if people decide, okay, I want to stop PrEP for a while, then they must take 28 days after the last potential at-risk sexual exposure. So, and then we talked a bit about before with people with chronic hepatitis B. As I said, there has been some changes to whether or not some people could come off PrEP, but that would be sort of a more specialised clinical assessment as to whether or not that's appropriate. So, so when people are finishing taking PrEP for whatever reason, it's always a good idea to know why they're stopping. Is it for side effects? Is it because they simply don't need it anymore? Or people may have gone into a monogamous relationship. But it's always good. I always say, oh, you've stopped taking PrEP. How come? And then sometimes the answer is, oh, well, I've got, 3 or 4 regular sexual partners. They all tell me that they're on PrEP, so I don't need to worry. And I'm like, well, I often hear people that are not taking it properly, they're not taking it reliably, and they're also not taking PrEP or not reliably because they're relying on their other partner to be taking PrEP, and then that person relies on that other partner. So I would always say, well, consider the fact that they may not be taking it properly, and they may not have told you that they've missed doses. So I would just recommend that people say, look, if you're taking PrEP, you don't need to worry about what's happening with anybody else. So, I mean, especially if you're just going to, meet people on Grindr, don't trust anybody, basically. Yeah, Jess, I'm certain that you do, yes.
So just last week here talking about the future of PrEP, and we'll come back to the other questions in the chat after. So there is on the horizon, so this has recently been approved by the TGA. This is a novel drug. So it's a capsid inhibitor, so it works in preventing the HIV replication cycle in an entirely different way to the current medications that we have available both for treatment and also prevention of HIV. And this is called lenacapavir. And this again is an injection of PrEP. And this is given into the abdomen, and it's given every 6 months. So it's 2 injections in one site, and then only having to do the injections every 6 months. So, so again, they did have a longer time there between doses. Does require an oral loading dose, and so we have there, and within when it's given the injections, and also the following day. And then doesn't require the ongoing oral pills as well. It's currently going through some other clinical trials as well, and they're investigating, looking at the efficacy of injections of a yearly PrEP, which would be incredible. So there's something hopefully down the pipeline. It's been shown to be safe and effective for cisgender women, cisgender and transgender men and women. So the trials, the first line of clinical trials were done in populations of women, and then have done the trials have been done from the start with diverse groups as well to ensure the efficacy across all different bodies and all different populations. And this actually comes to your question that you have there, Soap, around does HRT for gender diverse people impact PrEP use at all, specifically for trans women. So I mentioned before about for indications where maybe on-demand PrEP isn't suitable. So when people are taking the answer to certain particular hormone treatments, hormone therapies, that it can have implications with on-demand PrEP. I'm understanding that daily PrEP though is still suitable though when taking that 7-day lead-in period if people are on HRT. Yeah, cool. So the on-demand PrEP can still be taken with the lenacapavir as well. So these the clinical trials will show that there's been no interaction between lenacapavir's effectiveness and also gender-affirming hormone therapies as well. So they have made sure that there's extensive research into that done as well too.
Yep. And just on the So this particular injection is every 6 months. The cabotegravir, the 2 monthly injection, the company is actually doing trials now to see if that can go to 4 monthly. So when it is eventually approved on the PBS, it's again, it's going to be absolutely brilliant because people can be getting a 4 monthly, 6 monthly injection, maybe even yearly. And so for people that are traveling, then it's absolutely ideal. They don't have to take tablets with them. There's not the risk of, maybe going to certain countries around the world where it could out them, and you can travel freely without having to remember, oh, did I take my PrEP? Did I not? Did I not? So, so for trans women, it's always daily PrEP. Jess, yeah. So on demand is still not recommended. Oh, sorry, trans women.
Yes,
I beg your pardon.
On HRT.
Sorry, take that back. Yes, you're right.
Yeah, well,
ignore me.
I
just saw women. Sorry.
Yes, yeah. So it does get confusing on it a little bit. Yeah.
Because I see trans women as women and I see trans men as men, and then you go men. I hang on cisgendered men. So anyway.
Alrighty, so quickly a couple of supports and referrals. So I will send through all this information and the slides and everything in the follow-up email with the and also some other, I guess, little goodies, just an email with some attachments. But so in terms of sexual health for the community, so South Terrace Clinic, M Clinic, and also Royal Perth Hospital, the Ainsley House, and sexual health clinic there as well. And obviously there are other sexual health services too, but these are particularly implications for PrEP, and then also with the Medicare and eligible PrEP access too. For more information around HIV and STIs, of course, you're always welcome to turn to WAAC, and also for other trainings, all your training needs, let us know, reach out to us. So ASHM is where you'll find all of the guidelines around PrEP prescribing and PrEP management. They have got a new site. So previously the PrEP guidelines were very windy and quite hard to navigate through, all the different nuances, different tabs, and it was very hard to navigate. They now have they've cleaned up the regular PrEP guidelines, and they also have a new website as well around if you're introducing to PrEP prescribing and PrEP management. And they have videos. It's really interactive for clinicians. So I will send that out in the follow-up email as well. So highly recommend having a look at that. They also have interactive tools as well, saying to look at is PrEP right for your clients, and kind of going through different examples as well. Health Equity Matters is the overarching national body for HIV and AIDS organisations and councils across the country. They do a lot of advocacy work, a lot of education work in this space. Of course, the Australian STI management guidelines for all your STI management guideline needs. And then, so I mentioned Get PrEP and also PrEP West. PrEP Access Now is another website around information for people accessing PrEP. They have information if people wanting to access PrEP for overseas pharmacies, the different schemes available with that as well, and also information to for PrEP prescribers as well. So kind of a one-stop hub around PrEP, and that's nationwide as well. So that is at the end, exactly at 1:30. That is the end of our part of our presentation for today. So really appreciate any feedback that you have. So we do have the QR code there. Otherwise, in a second, I will pop in the link to the chat. Really appreciate any feedback that you have. We're trying to make have a bit more of an ongoing webinar kind of routine, I guess, or scheduling, maybe a better word. And so if you have any topics that you would really like covered or want to know more about that we might be able to support you with, please let us know, or any feedback for today. But otherwise, I'll stop the recording now. Really appreciate everybody's time today, and welcome if you have any more questions, pop within the chat, or when I stop the recording, I'll turn your microphone on as well. But thank you all. Yep.